We then looked at if health centers were in what phase of implementation they were in the next 12 months, and about 90% of them, 80-some% of them, were already planning to implement electronic health records in the next 12 months. The source of funding is important because the health centers receive some monies from other grants, but most of the funding came from their operational budget in order to implement HIT to begin with. We need to look at how many sources of funding. So it takes health centers a great deal of work and effort to get the funding to implement the EHRs, and what we found that 50% of all the health centers have more than one source of funding that they had to use in order to implement HIT. And almost 10% had to look for 4 different sources of funding in order to do that. So you can imagine the time that it takes to dedicate a staff to competing RFPs, tracking the RFPs, getting the money, tracking the money, all that. So there's a lot of work that goes into just funding the front end of the EHR activity. This identifies the disease registries. HRSA began to not support the disease registries about 2 years ago. They were supporting them for a while. The important piece here is that most health centers are continuing to use the disease registries. That's ingrained in their culture in terms of continuous quality improvement and managing the patient population. So they're further ahead of the game, we think, than many other individual providers. Again, we looked at that health center controlled network and compared that along the lines of planning to implement. And what we found that if a health center was part of a health center controlled network, they were more likely to be in process of implementing an EHR. We compared that to then those health centers that responded that were not part of a health center controlled network, and it was surprising. I had to look at the data a couple of times, but none of the health centers that were not part of the health center controlled network were actually in process of implementing an EHR. So that support from the health center controlled network is very, very important. Another area that's an issue for health centers are the issue of staffing and workforce on the HIT side. Most health centers have an HIT person, but about 40% of the health centers that responded don't have an HIT person. They don't have somebody that they call a CIO or an MIS director. That's how we worded it. So 40% of 1,200, I don't know, that leaves about, what, 800 health centers or so that don't have an HIT person. So in order to implement EHR, there's going to be significant hurdles for them to get over that hump, even if they do have funds to implement. As you can see from this slide, it really identifies where they get those services for. So many of them are contracting those arrangements out to other sources. In terms of donated services, it was surprising. I thought that health centers would have been more along the lines of receiving more donated services from other providers, maybe hospitals in the area who they share patients with, but that didn't seem the case with the health centers that responded to the survey. So 78% of them are not really receiving any donated services. So that was a surprising number. Board involvement is a good indicator of moving forward and having the capacity to move forward. So most health centers, 85% of them, the board was involved in HIT initiatives with the health center. And again, most of them had, over 75% of them had HIT as a part of their quality and or business strategy. So that's important that they incorporate that up forward. And then we asked about the identified needs to build HIT capacity. And once you get past the first two, which have to do with funds for implementing and funds for ongoing maintenance of EHRs, the next three areas are really where health centers have difficulty are in redesigning workflow. Because when you put in your EHR, you're not going to just duplicate your paper process, so they need to redesign workflow. Using the technology and using the data to improve clinical care, so they need assistance along those lines. And also issues regarding connectivity. Because they have more than one site, they have needs to connect those sites together. And if 40% of them don't have a CIO or MIS director, well, who's going to do it? Sometimes it gets left to the CFO in the organization, which they don't necessarily have those higher technical skills that it takes to link a number of different sites together. We then looked at maintaining and use of a website. And most of the health centers have a website. However, the higher functions of using that web to interact with patients, they don't have that incorporated into their systems yet. The EHRs, most EHRs don't have that incorporated into their systems yet. So going down the road for meaningful use, they're going to have to ramp up and be able to provide some of that communication with patients so that patients can schedule appointments, see their medication lists, see their last visit notes, things along those lines. We then looked at telemedicine services, and about 60%, 50% of the health centers that responded were actually recipients of telemedicine. So there's a lot of telemedicine activity that goes on in the health center world. We think that could be expanded greatly, but from those centers that responded, many of them are already recipients of telemedicine services, and about 30% of them are providers of telemedicine services, so they're the actual consultant. And when you look at the types of telemedicine services, if you combine the behavioral health services, adult psychiatry, and then also other mental health and behavioral health, if you combine those, it's really behavioral health services are the most used telehealth services by health centers. After that, you have dermatology and then chronic disease. So it's really on the behavioral health side that they're using those services the most. And then we looked at those health centers that were providers of behavioral health, telehealth services, and again, it's the behavioral health services that are most often provided. And then they're also using telehealth for non-clinical applications. And this is going to be important going forward, both in rural areas and urban areas. I know there's some challenges with some of the legal issues in urban areas, but we're hoping that some of those laws may be able to be changed, because 10 blocks in an urban area is just as far for someone to go who's elderly as 100 miles in a rural area for someone else. And that would end my part of my presentation, and what I'd like to do is now turn it over to Nicole Lamoureaux from she's the Executive Director for the National Association of Free Clinics, and then she'll pick it up from there.
Thank you very much, and I'd like to thank all of you for having us here with you today. The National Association of Free Clinics is the only nonprofit organization that's job is to represent the 1,200 free clinics in the United States of America. And we were founded in 2001. Free clinics are a volunteer-based organization, so our association was run for 10 years with a volunteer board and decided 2 years ago to hire their first executive director, though we were founded in 2001. And our job is to provide research, education, and resources to support our member free clinics and the communities they serve. But normally the question I get all of the time is, what actually is a free clinic? What does that mean? So what a free clinic is, we are volunteer-based safety net healthcare provider organizations. We have some paid staff, but we mobilize tens of thousands of volunteers a year to provide services to the nation's uninsured. We are 501c3 organizations, all of us. We have a board as well, and no patient is turned away for their ability to pay. And when I say that, I think what the important thing to remember is we do not have billing systems. We do not bill insurance at all. We may have a smoking cessation program, for example, and that may be $3 for you to come and stay afterwards to learn for photocopies. If a patient cannot do that, we do not disqualify them. No, everyone is served when they come in. If a patient does qualify for some sort of insurance, we help them and walk them through that program. We do not keep them on our rolls at the National Association of Free Clinics or our free clinics around the country. There are 1,200 free clinics in the United States right now. We've been around since the 1960s is when they were started, though some will tell me they started when they got off the boat and we landed here. So somewhere between then and the 1960s is when we really started. In 2008, we serviced 4 million patients. We are actually estimating that that's going to be 8 million patients because of the current economy. We have seen an increase in our patients 40 to 50% from where we were last year at this point in time. My next bullet point says tens of thousands of volunteers. Last year we realized that we had 6 million volunteers throughout the nation working with free clinics. We see, as you can see, 58% female, 42% male. Our major group of patients is 18 to 65. That's who we normally see. However, if anyone below that age or above that age comes, they can't they don't qualify for something else, there is no service, or they're very, very sick, we will see them. 83% of our patients come from a working household, or they did before this economy, and we service primarily 100 to 300% below the poverty level. We have on-site pharmaceutical services. We provide dental, vision, mental health, primary care, chronic care, and prevention services at free clinics as well. 44% of our clinics work on an operating budget of under $100,000 a year. And that is because we do have so many donated services within the community. We work very closely with our hospitals, our labs, our specialists, and we ask them to give back. And we have found that part of the corporate giving campaign that many of the communities have, whether it's the hospitals or even the restaurant down the road, will help us a great deal because they want to give back to their community. We really are the community's answer. So, for example, after Katrina, there was a clinic that was started in the parking lot of a jitney jungle by a woman and a man who were 87 and 84 years old respectively, because they realized there was going to be a great deal of respiratory problems in that area. So that clinic focuses primarily on the respiratory problems, and they work very closely with their partners in that area as well. As I said, we've seen an increase in our patients 40 to 50%. It is not odd to see patients lining up at 1 or 2 in the morning for the clinics that are opening up at 7 o'clock to be seen that day. And we have a minimum economic impact of, for every $1 donated, we can provide $3 of services to a patient. Our new numbers that will come out in January will say that for every $1 donated, there will be $25 in services. That's because we've had such an increase in our patients and actually an increase in the donated services that we've seen over this last year. Free clinics, some very important facts. We are not part of the current healthcare reform debate at all. We haven't been invited to the table. We operate with little or no state or federal funds. We do not receive any money from the federal government or state government. If we do, it's very, very minuscule, and it's most likely for something in conjunction with the community. So a new road needs to be built in front of a clinic is really where they see the money, as opposed to going to a clinic. And we're not named as recognized entities in the stimulus package at all. So any of the money under the HIT funds, under the stimulus package, that we had identified a few different areas, and when we delve deeper, we do not qualify for those programs. And the question I get a lot is, there are loan programs. Well, when you operate a clinic under a budget of $100,000 or under, our clinics are much more impacted to use that money to service their patients instead of default on a loan that sometime they can't pay off at some other point in time. So I am here, I guess, really to say that we have some real barriers to adoption in the free clinic world, and the great part about being on a panel like this is seeing that the barriers to adoption are across the board.